So our next speaker is RIO Amritsar Chief Karamjit Singh, a wonderful human being, a prolific surgeon, absolutely humble and good in his work. He is training in 2mm to his students, and he has given thesis to his student to on 2mm MSICS. Karamjit, please.
Thank you, sir. Good afternoon, respected chairpersons. So my presentation is basically what I learned from Dr. Sahu's 2mm manual small incision cataract surgery. So as we are discussing these days the construction of the scleral tunnel and the size of the incision. So the scleral tunnel, it is basically evolved for years. So we started with the type of incision, then we went on site and size of incisions. So mostly previously it was debatable that the temporal incision is better, spirotemporal is better, or superior is better. But now with the reducing size of the incisions, we can overcome most of the complications or most of the outcome which is there post-operatively. So these days we are basically doing topographic guided incisions on the steeper axis as discussed by our previous speakers. So with 2mm manual small incision cataract surgery, one can have a better control over pre-existing corneal astigmatism, and it also reduces post-op astigmatism almost to negligible. So incision construction, it is very much important. So I am showing one of my initial videos. So basically I am practicing 2mm incision, which is approximately 2mm, 1.5 to 2mm behind the limbus. So the initial incision is 2mm, and after that I give back cut of approximately 2mm, rather exactly 2mm towards the fornix. So practically the size is 2mm only. So this the keratome and the tunnel blade which I am using, it is of 2mm only, which is basically from the Epsilon. Although I have no financial interest, so these days 2mm keratomes are available. So previously people used to ask that you are using 2.8 keratome, then why then the incision is not 2mm, but I am using 2mm keratome these days. So initial sclerocorneal tunnel, it is very easy to construct the tunnel with the tunnel blade if you are in right plane. So see, practically the incision is approximately 2mm only. Then after that a good large capsular axis as usual, as we are doing, and a good hydro procedure to basically prolapse the nucleus into the anterior chamber. Good hydro procedures are required. Now the main part is nucleus prolapse, and after that it's a delivery out of the 2mm scleral tunnel. So we prolapse the nucleus as we are doing in manual small incision cataract surgery, and after that with Dr. Sahu's specially designed 2mm vectors, so I hold the nucleus with good viscoelastic material, and with visco cannula I divide the nucleus into two pieces. So see how easy it is to divide the nucleus into two pieces. Even these days I am dividing into 3 or 4 pieces also. So then it is very easy to prolapse that nucleus out of the scleral tunnel, and see there is no pressure on the scleral tunnel. And this is basically in the bag that I learned from Dr. Sahu only. So it is basically in the bag division of the nucleus into two. So it is nucleotomy within the bag. And after that this is also expression of the nucleus first into the anterior chamber out of the bag. Then after that it is very easy to divide that nucleus into 2 or 3 or even 4 pieces, and with 2mm specially designed vectors which is easily available these days, out of the 2 mm scleral tunnel. And after that we can implant foldable intraocular lens. If your incision is a little bit large, your tunnel is a little bit large, even we can implant 5.25 or 5.5 non-foldable intraocular lens also. So this is, I feel that this is very good technique. So so these are the few instruments that I am using for nucleus management. So these are specially designed by Dr. Sahu sir. Thank you, Dr. Sahu, for giving me this instruments. And after that, IOL implantation as usual. So basically I want to show the results. That video is not coming. So basically this technique 2 mm incision has all the advantages of phacoemulsification. It is less time consuming and few instruments are required. It is indications depend upon surgeon's experience, skill and expertise, but it is not a technique of choice for the beginners, and it has very less complications with the experienced surgeons. So I did more than 200 cases with this technique, and my astigmatism is average astigmatism is 0.8 diopter only. And there are few complications. For first few days we can encounter edema at the incision site, at the sclerocorneal tunnel. Superior corneal edema may be there, and but that subsides after 5th or 7th day, and there are minimal complications. The average endothelial cell loss that we encounter, so we are going to publish the 200 series of 200 cases recently. The average endothelial cell count is approximately 150 only, and there are few complications after experience. So basically I want to show my results, but I lost my pen drive somewhere in this conference. That's why I'm presenting this, the previously saved my PPT. Thank you very much for your patience.
Thank you, Dr. Karamjit. See this, you are telling about the tunnel making with a 2 millimeters. This thing, not necessarily. If you have a broader, cystotome sort of that thing, you can go from the side. If you go from the side, and then take the pocket from inside, that will also. You don't have to go straight.
Okay, sir.
So you go from the side and fasten your pocket.
But these days, sir, 2 mm blades are also available.
Just telling you.
Yes.
If somebody says somebody is not having,
yes, sir,
it is not a handicap.
So we can use 2.8 mm also.
Sir, can we take questions in between or after talks?
Yeah.
Yes.
Yes.
Can we take questions in between? Questions from audience.
It is better you take the question now, and so that they can
yes.
attend.
So any questions from audience regarding these two talks?
The procedure you showed that you practically broke the nucleus in the anterior chamber.
Yes.
Before taking it out.
Yes.
Don't you think, I have two questions to make. If we make it in a separate side port entry, that will cause less drainage of the HPMC.
But sir, then there are more chances to touch the endothelium when we are inserting the second instrument.
I think it's the other way. Once you are putting both the instruments from the same wound, chances of draining the viscoelastic is more. If you are making from side port, the chances of draining of the viscoelastic is less. You tend to get a deeper anterior chamber.
So sir, basically I am using the tapered visco cannula. So simultaneously I am injecting the visco in that. So there are less chances of leakage of the that viscoelastic. So I am not using simple cannula. I am basically injecting the viscoelastic into the layers of the nucleus. So that separates the nucleus into two.
And the post-operative results, as it can make out, there will not be any astigmatism practically.
Sir,
but how good is the cornea going to be the next day?
Sir, the next day, sir, we can find a little bit corneal edema at the incision side, at the 2 mm incision side, spirally or spirotemporally if you are doing spirotemporal. But that edema overcomes within 5 to 7 days. So little bit edema can be there if we are dealing with little bit harder cataracts.
Yeah, with such small incision, you can very well go for any sort of foldable multifocals.
Yes.
Okay.
Any other questions?
Sir, yes, sir, practically the outer incision is 2 mm only. So as the sir said that we can use 2.8 from side. So the first incision is 2 mm only. So if we are using 2.8, the incision can enlarge, or there is a little bit buttonholing at the incision site, sir. So that's why so I searched from various companies the 2 mm keratome. So it is readily available now, 2 mm.
Another question actually, this may be for the previous speaker. I have been doing SICS for last 20-25 years, and what I the simple question is, we are taking care of the corneal astigmatism part of it. We are whatever we are doing, we are taking care of the corneal astigmatism part.
Yes.
I have come across cases where preoperatively I have hardly any corneal change, postoperatively cornea is very fine, not much of astigmatism. Even then, I am getting -2 or -3 cylinder, which subsequently I tallied with the auto-ref, it tallies there. Must be he was having some denticular astigmatism or some other. Is there any way to take care of that part?
Sir, see, this is that's why we have a research platform now, Batical.
Yeah.
So you do focus on that. He is focusing on something, you focus on that. He is not focusing on this
Other parts of the astigmatism. Yeah.
So you take over from there now. You focus and bring your some paper.
Sir,
So
we can manage the corneal astigmatism with the incision construction, the size and site of the incision.
I think the same
But-
with phaco also.
No, sir.
Yeah.
To answer your question, you said that the post-operative K values are almost similar, but you get a result of -2 or something in the outer F finding.
Yeah, that's it.
So that means there is a lens still.
Yeah.
So that means there is a jonular weakness somewhere, or one of the haptics could be above and another could be below the rexus margin.
And that was there previously also. Subsequently, I checked in the previous autograph readings that used to show -2 or -3 cylinder.
See, it is not possible that
You can't correct by that.
No, if you have a lenticular
time ho jayega.
surgery,
Yeah.
there is
I
no
thought
more
it-
lenticular surgery because it's removed. So if the
So I wanted to
haptic
finish
is
it.
placed exactly parallel to the corneal plane or pupillary plane, there should be no astigmatism because that is removed. Theoretically,
Okay.
you cannot have a K value having 0 and a lens parallel to the limbus and still having -2 cylinder.
Okay. So we will now go for the next.